Sara was hoping to be with us here in person, but she's currently in transition in Greece. Thank you, Sara, and thank you so much for trying to present at the airport.
Hey, thank you.
So Sara is an associate professor in community medicine, and she was the ex-director general at White Nile State. So we get to hear a bit of practitioner experience.
Hello, everyone, and thank you, Noon, too. So I'm going to present the experience of the White Nile State regarding COVID management and what challenges we had considering the economic recession that Sudan was going into during the civilian government. The presentation outlines, we will talk a little about the problems in the White Nile State, the White Nile State situation, the COVID-19 situation, how we managed it, and what we did to strengthen the system to be able to reduce the epidemics as well as the COVID-19 pandemic. So mainly, when I first started my work as Director General in the White Nile State, we had a very poor management system at all levels. And one of the main issues was that we didn't have a proper governing system. There was no workflow system. We had poor implementation of guidelines. There were so many lobbies in the healthcare system that were working against each other. The other problem was the weak health information system and the poor surveillance system, which really was a problem for us to be able to manage and at the same time to send adequate data to the Federal Ministry of Health. There was severe shortage in the number of healthcare cadres at all levels, and the White Nile State being a rural state, or at least 90% of the population live in rural areas. We had issues where most doctors wouldn't work in any primary healthcare center or rural hospital. Environmental health problems were present at the primary healthcare level, the secondary care facilities, and at the locality level. We had issues with water and sanitation. And at the same time, besides all of this, our state that harbored around 199,000 refugees, mainly from South Sudan. And this was a very big problem during the COVID pandemic. And the state is prone to floods, epidemics. And in 2017, we had a very big one of the worst outbreaks of cholera. And in 2020, we had chikungunya. We're also prone to dengue fever, but I'm glad we didn't have any dengue fever epidemics during the COVID pandemic, despite the fact that we border 6 other states. And there was dengue fever in 2 other states. And one of the worst nightmare for me was the funding issue. We had no fund allocated from the Ministry of Health, the federal level, or from the state. In Sudan, we have a decentralized system, and the state should provide the budget for the Ministry of Health. Unfortunately, this was a problem in the economic recession. I'm just sharing a few photos so you can all imagine how our primary healthcare and rural hospitals look like. This is a rural hospital, and this was during the at the end of the flood season, the rainy season. This was a water source in one of the localities. This was one of the primary healthcare centers that I visited. This was, I shared my photos because I didn't have time to get people's consent, and the person at the back is one of my staff. This was during the flood season. Despite all of those, then the COVID-19 pandemic hit the state, and the situation was even worse with the poor healthcare infrastructure, the poor surveillance system. We had high brain drain. Again, the epidemics and the poor economic status and the high unemployment rate in the state was also a problem for us. The low literacy rate, which affected most of our education session and increased the stigma at the level of the society. And at the same time, I believe, even though we didn't do any research, but I believe one of the issues was with the stigma is that most people in those rural areas depend on each other due to the low socioeconomic status. So there might be in one locality just one car, which can actually drive people to the closest rural hospital. So people depend on each other, and they wouldn't want to say that they have COVID, and they would rather stay at home with those symptoms because they fear isolation from the community. And the low socioeconomic status and the low literacy rate in the state is actually added to our problems of stigma. There was the high refugee influx, and we had poor border monitoring and surveillance, border surveillance system. And we actually identified a case of polio that was cross-border. And then the stigma, as I mentioned, COVID, cancers, and diabetes. What we did to be able to manage the COVID-19, we looked at one of the nice models that I like from WHO, and we started working on the governance and financing block, the health workforce, medical products and technologies, public health functions, health service delivery, and then had to interact with the community so that we can actually advocate for many of our activities. We looked at health equity and how we can provide services to those vulnerable and rural areas, as well as IDPs. We've got a very small percentage of IDPs in the community, as well as the refugee population. And we also worked on collaboration with the other sectors. In the governance and financing, we the first thing that we did was have a committee, a higher COVID-19 management committee that we formed at the governor's office, and we wanted to give it power and strength so that a governor can actually be able to lead the management of COVID at the state. And this included the police force, the education sector, the border monitoring police, and security forces. And we also could call upon people that we deem important for the committee. This committee was able to pass many policies, and the healthcare sector was the main sector that used to recommend those policies, such as policies for wearing masks, selection of criteria, because at some point we had to reduce the number of workforce in different institutions, and we had to have a criteria for who will stay home, who will be reduced, who will have their hours reduced, who will get more incentives as working in a high risk area. We also had, we passed traffic rules, such as we closed the state down. We had 3 of the states that are bordering the White Nile state, Khartoum state and Jazeera state, had a very high case fatality rate and very high incidence rate of COVID. So we had to close our borders, and we passed a law where all cars that are coming into the state, especially, no car would be coming into the state unless it was a food or a petrol cars as well, and vehicles, as well as the emergency supplies were allowed to pass into the state, and they had to be disinfected, and we had data. People who were driving those cars were monitored. And all of those were passed by this committee. We strengthened the border monitoring surveillance system, and we actually were able to establish clinics, and we had people trained who could actually monitor people coming in and out of the country. And we had a small isolation center where people could stay until we get the results. For the financing aspect, as I mentioned before, we had issues with financing, but we were able to work with INGOs and NGOs, and they funded most of our activities. We turned to philanthropy as well as diaspora in different countries. We coordinated with all those people, and we managed to get a lot of supplies, and most of our gene expert machines, as well as CPAPs and ventilators, were brought in by those sectors. In the health workforce, we had a committee that was formed for selection of health workforce, and at the same time, we wanted to discuss issues on incentives, recruitment criteria, and then after we identified our staff, We started doing capacity building for different sectors, for laboratory people, for pharmacists, people who are working in primary healthcare. We had volunteers as well who were working with us. And we had rapid response teams who had regular training and refreshment trainings in localities. And those were the people who were able to identify our suspected cases. We also relied a lot upon the health promotion department to reduce the stigma around COVID-19. In the other building block, the medical products and technologies, we had a committee that assessed and regularly monitored the needs of the COVID pandemic. The committee coordinated with the emergency department and it was one of the committees that was also coordinating with the National Supply Fund. And we were able to supply a lot of the medicines, the personal protective equipments, the PPE, the devices needed for the management of COVID-19. And the isolation center was fully equipped with the needed devices. And one of the issues, we needed a lot of ethanol for the disinfection. We started producing. The pharmacists in the state were able to form again another committee that helped us as the Ministry of Health to produce ethanol at the state level. And this was after the production, and we used to send those big jerry cans to the hospitals and primary healthcare centers. The public health functions, we coordinated with different sectors. And one of my worst nightmares was the regular outbreaks of diarrhea in the state during the floods, as well as cholera epidemic. We coordinated with the water municipality for monitoring residual chlorine to prevent outbreaks of cholera and diarrhea. And to be honest with you, I was really under stress. I thought if we get cholera, outbreak of cholera and COVID at the same time, no one will be alive in the States. So our coordination with the water municipality, as well as many organizations that supply the chlorine in the state, actually did a very good job, and the diarrhea rate remained very low during that year. At the same time, we had no cholera outbreak. We formed an INGO forum to coordinate donations at the state level and coordinated with the police force to reduce the floods damage. We had one of the worst floods during 2020. And I'm really happy to say that we were able to coordinate with different INGOs and local NGOs for the distribution of NFIs and monitoring of COVID cases. This was one of our meetings. In the health service delivery, we were able to establish a good isolation center. I will show you a few photos. We also established primary isolation centers in secondary hospitals and established the policies and regulations of primary healthcare centers to reduce COVID transmission. I know that a few states closed down the primary healthcare centers, but in our state, we decided that we should keep those primary healthcare centers open. They will reduce the burden on the hospitals. At the same time, we thought that we have a lot of chronic diseases that can't really keep on coming to the hospital and get exposed to COVID. But we regulated and monitored the primary healthcare center, the mask provision at the centers, the social distancing in the center. We also regulated the private clinics. We did not close down the private clinic. Any doctor that wanted his or her private clinic to remain open, they had to come to and register at the Ministry of Health, and we would send a team to the clinic to make sure that the clinic was in line with our preventive measures. Prepared an isolation center for comorbidities, and we prepared a center. I'm glad we didn't have to use it for cholera and COVID patients in case we encounter the cholera outbreak. establish an isolation center at the borders and clinics. And this is the isolation center that we established. This is the if you remember at the beginning, the ward that was the service itself, and the ward was in mess. We were able to renovate it. These are the regular disinfection in hospitals, and we passed different laws and policies for disinfection according to the WHO. And these are the donations that we kept on receiving from INGOs, NGOs, philanthropy. As a result of the COVID, we were also able to receive different machines such as X-rays and in the state. This is the refugee camp. This is the meeting. This was a meeting with gatekeepers in the community and religious leaders. This was the center isolation center that we established, and this is the center inside. And we had people trained to be able to screen for COVID, and this was one of our staff. At the community engagement, we collaborated with religious leaders to help us reduce the stigma, and they advocated for this at the community level. We had to interact with them because we also closed down at some point the mosques. And when we reopened them, we had to get them along to support our policy. We also interacted with the community leaders and resistance committees. These were committees that worked during the revolution, and we trained them by the health promotion department, and they helped us with peer education. They were trained to promote preventive measures at community level and advocate for COVID-19 immunization once it was provided. And these are a few of our trainings. Then we realized that it's not enough for us to work on the COVID-19 management. We looked at the 6th building block, and we started strengthening the health system. I'll just go quickly. Again, in the governance and leadership component, and one of the building blocks, I think, which was important, we strengthened the state structure, and we coordinated most of our activities with the federal level as well as the locality level. Again, we established an accountability framework so that all stakeholders can actually partner with us, as well as international stakeholders. One of the issues that I really received help from was we established think tanks, and we had people from international colleagues who were able to help me as Director General to make a lot of the decisions and to plan, since COVID was a new experience for all of us. And we started to, so previously most people were selected and given director jobs based on their affiliation to the previous regime. So we started looking at criteria for allocating people to different leadership positions. In the financing system, we had a lot of issues with the financing, but we reviewed and strengthened the insurance system to help us be able to reduce morbidities among, especially among the vulnerable population. And we looked for other resource allocation, which was an issue for us. So in the service delivery, we tried to agree on the healthcare services and the packages that should be provided at the primary healthcare level, as well as the rural hospitals. We had a lot of secondary care facilities that were providing primary healthcare services, and that really put a lot of burden on the facilities. So we tried to look and we tried to review and strengthen the packages that were provided in each of the different levels, whether the primary healthcare or the primary or the secondary services. We at the same time started focusing more on preventive health system, and we looked at the improvement in water and sanitation, environmental improvement, which is also very important for different diseases as well as COVID. One of the issues that I mentioned before was the preventive services, and we thought nutrition was a very important aspect. And we had 36% of our the 5 had stunting, and I thought that this wasn't a survey done by the Ministry of Health, but we were working in collaboration with MSF. And these results were brought in by MSF, and that again was a very alarming point. So we started working on nutrition services, and we basically started concentrating more on the primary healthcare service to reduce a lot of the mortality and morbidity at the state level. One of the issues we also concentrated on was the reproductive health and maternal health services. We had very high maternal mortality rate due to so many different reasons, but one of the issues was the accessibility issue, as well as we really had no doctors and midwives at the level of most of the rural areas and localities. So what we did was we had traditional birth attendants. We concentrated more on basically training them and getting them certified. And we also started concentrating on task shifting. Since there were no doctors who could fill in most of the primary healthcare and rural hospitals, we thought it is best if we focus on task shifting. Again, we provided the COVID-19 vaccine, and this was a big problem. The vaccine absorption rate still remains very low in Sudan, even after I left the White Nile state. But we had a lot of advocacy, as well as we used the community to help us with raising awareness of people, and to try to reduce the misinformation, disinformation that was being passed on through Facebook and WhatsApp by many people. We also introduced polio campaigns since we realized that we had one case that came cross-border into Sudan of polio, and then we discovered 2 other cases. Now in total, we had 3 cases of polio in the White Nile state. And in collaboration with the Federal Ministry of Health as well as WHO, we were able to have different campaigns, of 2 campaigns actually, of polio vaccination to all under 15. And this was also later on done in other states. We also coordinated with the private sector, and the private sector so we had in the state 3 sugar factories and 2 cement factories. We coordinated with them as part of their social accountability to use that 20% for the health sector. We also strengthened the occupational health department and the policies and the provision of personal protective equipment by those factories to people, which also helped us on the COVID management, pandemic management, as well as other diseases as well, especially the chronic diseases such as asthma, which was also very common according to a previous survey. The health system workforce, we basically reviewed the policies for recruitment and retention. We thought if we don't give doctors some sort of incentive or a package deal, no one will actually stay in the state that was mostly rural. We also coordinated with the governor, and we thought if the government doesn't take the issue serious and provide schools, strengthen the education system, no doctor would want to come and stay and work in the White Nile state. So and the housing, but unfortunately we did pass a few policies. But I left after the military coup, and I'm not really sure what happened. But I know the governor was very much interested in making sure there is at least 2 or 3 private schools for doctors who come to work in the state, as well as provision of housing to doctors from outside the state and their families.
We might have lost her again. I think she was worried that her batteries were about to finish. We can start the questions now. Sarah, sorry, just to say, we're not sure you're joining, so we're starting the questions now. Is that okay?
Yeah, that's okay. Thank you.
All right. Thank you.
My name is Fath Loba. I live and work in Liverpool. I don't have a question for you, Sarah, but your work has been exemplary, really. I salute you for that effort. Thank you.
Perhaps, Richard, you can share the questions from online.
Thank you, Noon. We've had a couple of comments online. One comment commending Dr. Sara's work and saying that the pictures speak out loud. They speak for themselves.
Thank you. Yeah.
Well, thank you very much indeed. I really do commend the 3 speakers. I have one question. The West is suffering from the effect of COVID economically. The work habit has changed from office to home. Businesses are closing down. Has any information filtered to the 3 speakers as to the effect of COVID on the economy of Sudan and South Sudan? Thank you.
Noon, do we want to pass to Sarah if they have any comments about response to Ahmed's question about the economic effect of COVID in Sudan?
Yes, thank you, Richard. I don't have a solid, concrete research, but I know during the COVID in the White Nile state, we closed during the lockdown. We had a lot of issues with the economy. One of the problems was, so basically I was Director General for the Ministry of Health and the Social Development Ministry as well. And we've got people who actually have daily jobs, and when we closed down markets and most people had to stay home due to the lockdown, we had a lot of issues with those people. Their daily jobs, they had no income, and as a result there was issues with nutrition, there was issue with food supply at the level of the house, their own families. So we had a lot of trouble, and we had no way to help them really. I know that many people as well lost their businesses, the private ones, and they had to restart working again. But I don't really have an actual research, and I don't know if the government actually did a research on this. And what we did do when we realized how people were affected by the economic problems, we released a bit the lockdown. So we allowed people with the preventive measures in place to open their markets and their business, but it was only until 4 o'clock in the evening. So this was one of the ways we tried to reduce the economic impact due to COVID.
But yes, a lot of people suffered during the COVID pandemic, especially during the lockdown. Thank you.
Thank you, Sarah. I think we'll close the first panel. Once we come back, we'll have the next panel, which would be Dr. Sandra Banks and Dr. Ayak Scholl. And then the third panel of the day, we've got Dr. Samuel here and Dr. Bethana, who are with us in person. Okay, thank you. Thank you to all the panelists. Really great presentations.
Thank you. Bye-bye.